Hi, I'm Dr. John Kane, Chairman of the Department of Psychiatry at the Zucker Hillside Hospital and Professor and Chairman of the Department of Psychiatry at the Hofstra North Shore LIJ School of Medicine. Welcome to today's program, an expert discussion, the extensive journey to our current understanding of schizophrenia. Joining me are Dr. Jonathan Meyer, Assistant Clinical Professor of Psychiatry at the University of California in San Diego, and Associate Clinical Professor of Psychiatry at Loma Linda University in Loma Linda, California, and Dr. Peter Wyden, Professor of Psychiatry at the University of Illinois in Chicago, who will be participating in today's interactive discussion. Before we get started with our discussion, I just wanted to point out a few items. You can submit a question at any time during tonight's program by typing your question into the Q&A tab on your screen and clicking the Ask button. In addition, you can change your view of this program by using the buttons on the bottom left side of your screen. The program is presented on behalf of Genentech, and the information presented is consistent with FDA guidelines. Doctors Meyer and Wyden and I have been compensated by Genentech to serve as faculty for this program. This presentation was developed in collaboration with the faculty presenters and other experts who specialize in the management of people with schizophrenia. The purpose of this disease education program is to improve the diagnosis of schizophrenia and the identification of its symptoms, as well as to increase the understanding of the etiologic mechanisms of schizophrenia. Please remember that this is a disease education program. Therefore, we will not review information regarding a particular therapeutic drug or device or answer questions pertaining to a therapeutic specific drug or device. Additionally, we will discuss topics relating to patients or subset of patients with schizophrenia in general. This program does not relate to a specific patient. Therefore, questions relating to specific patients will not be answered in this forum. Let's begin with an overview of today's program objectives. During this program, we will review the far-reaching impact of schizophrenia and provide insight into the current state and advances in the diagnosis of schizophrenia. Next, we'll discuss symptom domains, their identification, and their impact on disability. Lastly, we will present evidence of the glutamate hypothesis and the potential role of NMDA receptor hypofunction in the pathophysiology of schizophrenia. I think it's important to first discuss the impact and implications of schizophrenia. And Peter, could you please speak to that?
Well, thanks, John. And I think if you're in the audience listening now, you know schizophrenia is a difficult illness. You've probably learned that it affects 1% of the population. It's less well known that it is one of the 10 leading causes of disability across all medical diseases in the world, way up there among young people in the United States. Also on this chart that you see, if you compare it to other very serious illnesses such as type 1 diabetes or multiple sclerosis, it's more common and more disabling. And I point that out because I think sometimes the stigma of schizophrenia, you don't think of it as much as you do these other medical illnesses, which often get more coverage and more concern. So in the next slide, since we're going to talk about the biology and symptom complexes of schizophrenia for most of this program, I also want to point out that a lot of the disability and morbidity of schizophrenia can also, in addition to what we'll talk about, be explained by the stigma and the loss that the person has, and also the family structure. These are people who often do not meet the milestones in their lives. The other thing I'm going to say, even though it may sound obvious for those of us working with it, I think sometimes as clinicians, we lose sight of this. We get a little bit numb to this, and we almost take it for granted that people will be unemployed or not have relationships, and we don't really, I think, get as concerned about that as we should, John. And I think that's an important point.
Well, thanks very much. So I think the next question is diagnosing schizophrenia. And Jonathan, can you bring us up to date on where we are with the diagnostic criteria and DSM-5?
Well, as you allude to, DSM-5 came out in May of this year, and I think for those who have seen the book, there's some major changes. One, of course, is the removal of the Global Assessment of Functioning score. That's out. No more GAF score, although we'll give you something which might be able to replace it. More importantly, with reference to schizophrenia, there's been a simplification of the A criterion, as we call it. What you need is one of those top 3 choices right there: hallucinations, delusions, disorganized speech. You need one of those 3, and then you have to have, among the list of 5, at least one other. The other major change was the removal of subtypes, which have been shown not to be helpful. Poor validity, poor stability, poor reliability. These simply were not useful. In the end, we still have a clinically based diagnostic instrument for schizophrenia. And many have lamented this. The head of NIMH lamented this when DSM-5 came out. Why don't we have biologically based diagnoses? We would like to, and it's not like we haven't looked either. So for 20 years, people have been doing imaging research in schizophrenia. And here's a great example right here. Twin research with a pair which is discordant for schizophrenia. So on the top 2 pictures, you have the unaffected twin. The bottom 2 pictures are the affected twin. And look at the big difference with ventricular enlargement in the affected twin. So we've already found some ways to distinguish one person from another, at least among twin pairs with schizophrenia. But unless most of you have MRI scanners or PET scanners, you can't do these types of assessments. And in general, we would say this is probably not the way to diagnose schizophrenia still in 2013. So what is a more practical approach? Well, the more practical approach is to try to find what we'd call peripherally based biomarkers, something that you can send your patient to the lab for where they can obtain a blood test and look for things. And a lot of these are going to be genetic, but not all. There's also things called proteomics and lipidomics, which look at the expression of genes as either proteins or lipids. The eventual goal, though, as it is for all of personalized medicine, is that maybe we'll have sets of these biomarkers where we can perhaps predict disease conversion. You have a group of youths in an ultra-high-risk clinic. Maybe we can find some tests which are going to tell us who among these is going to develop schizophrenia. For those who are a diagnostic dilemma, maybe we'll have markers which specifically identify schizophrenia and are robust. And can we identify patients who will have different prognostic outcomes? Who will have a lot of negative symptoms? Who's going to have a lot of cognitive dysfunction? Who's going to respond to certain medications? Who's going to have metabolic problems from certain medications? And so these are all the things we want with our biomarkers. And unfortunately, though, as DSM-5 sort of confirms by its absence, they're not yet ready for prime time. But they do exist. And there's a number of clusterings that we found among these genes which show a correlation with schizophrenia risk. The problem is there's a large number of these genes, maybe 200 or 250 at last count, each of which contributes a small amount of the risk variance, perhaps 0.1%, maybe as large as 1%. And the problem we're confronted with is the predictive value is quite small and disease heterogeneity is quite large. Every person with schizophrenia has his or her own clustering of these genetic abnormalities, and it may make it very difficult in the near future to decide on a clustering of these which will predict anything: disease conversion, prognosis, treatment response. But still, this is the goal. It's the goal in all of medicine, and it's certainly a goal with a very serious illness like schizophrenia, is can we derive these things to augment the clinical reality that we have in diagnosing and treating patients.
So thanks for that review, and I also think it's important for us to remind ourselves, despite the fact that we look forward to having tests and biomarkers, that our ability to diagnose schizophrenia now with our current approach is actually very good. Mm-hmm. It's a highly valid and reliable diagnosis. So we need to keep that in mind as we look towards the future. And I think it emphasizes that the clinician has the responsibility to be aware of all of the different domains that can affect someone with this illness. And traditionally, we've divided it into 3 core domains: positive symptoms, things like hallucinations, delusions, disorganized thoughts; negative symptoms, which now have been divided into 2 essential domains: diminished expressivity and avolition and apathy. And then cognitive dysfunction, which involves problems with memory, executive function, attention, and so forth. And these are important because they have tremendous impact on long-term outcome and functioning. We also have to remember that patients with schizophrenia can experience mood symptoms, depression, suicidality, and at times even aggressive behavior. So let me ask you, Jonathan, which features have the largest impact on long-term outcome in patients?
Well, while many of us are impressed when we see individuals with florid positive symptoms, in the long run, though, it's negative symptoms and cognitive deficits which are the biggest predictor of functional outcomes. Unfortunately, it's still hard for many clinicians to get neurocognitive batteries on their patients. And as we will discuss extensively, we often overlook negative symptoms for a couple of reasons. Often these are less florid and they're less obvious. And secondly, a lot of these patients simply don't present acute problems. And so we often become nihilistic, as Peter mentioned, and particularly in the absence of viable treatment options for negative symptoms, they often don't get the attention they deserve despite their correlation with outcomes.
Yeah, Peter? I agree. Jonathan, you're really on target. I would add one thing, that what you do clinically will often depend on where the patient is at. So yes, if the person is relapsing or having acute positive symptoms, that is the focus, that is the priority. That's hierarchical. You do that first. Once you take care of that, which you can in most patients, then the other symptom domains become more important, relatively speaking. I think that's where we often drop the ball, and it's less of a crisis. It takes sort of more of a slow grinding approach, but shifting, where are we in this patient, what are the priorities, positive symptoms, we're not losing sight of that, but often you can focus more on cognitive negative symptoms. And I think we sometimes don't even think of that.
Right. So Jonathan, what proportion of patients, outpatients who are stable and who are taking an antipsychotic drug, what proportion of them actually have moderate to severe negative symptoms?
It's a great question. It actually ties in with what Peter was just talking about, is once the period of instability has passed and you have somebody on medication who's in stable outpatient treatment, as we see here, about 61% have at least one significant negative symptom. And although the data are not shown here, if you look at the long-term literature, somewhere between 15 and 25% of stable outpatients will have persistent, severe, primary negative symptoms. And we know this is going to correlate with lower chances of remission and poor functional outcomes. And so this is a highly prevalent problem among the stable population, but sadly often not addressed for various reasons.
And Peter, in these types of patients, I mean, what would you say is the typical level of functioning that you see?
Well, like Jonathan said, we know that functioning goes down with these symptoms. And the person loses a sense, you got to sometimes lose a sense of who that person is without schizophrenia. However, there isn't one big negative symptom. In that slide you saw before that Jonathan presented, there were many different negative symptoms. So some people may lose more social functioning and have no friendships, no relationships, and other people may lose more motivational functioning. They can't work, they have no drive. So I think it's important to not view negative symptoms as one thing, but focus on those different components and see where is that person losing their functioning. It also makes it a bit easier. You don't have to treat everything at once.
Jonathan, what do you think?
I agree. And actually, as was mentioned earlier, we've started to devolve negative symptoms into two large groups in terms of the symptoms: diminished expression and apathy and avolition. And we recognize that people may present with one or the other, or potentially, if severe, both of these. And as you start to look through some of the information we're presenting, we're hoping that you'll increase your sophistication, not only recognizing negative symptoms, but also the functional impact as well. And one thing I do want to make a point at, and this really, again, kind of echoes what Peter was saying, is where the person is affected may vary greatly between individuals. So here we have in this slide a bunch of groupings of different roles. Certainly activities of daily living are often impacted. Relationships, the ability to be employed, a sense of purpose, motivation. But also sometimes there'll be more basic things such as ability to maintain hygiene And then internally, there's often the anhedonia, which goes along with the amotivation. And some patients really lack the experience of joy in their lives or satisfaction as a core feature of their negative symptoms. And so where people can be impacted varies across the individual, but it can really be devastating in toto because of their loss of these human roles and these human abilities to develop joy in their life.
So schizophrenia often robs people of the things that we take for granted.
Yeah. So the question, people say is, well, that's fine. Well, what do I do about it? And so I think it's critical to understand that there certainly are ways to measure negative symptoms. One thing that has been developed over the years are various research instruments, which of course many won't use in clinical practice, but I think you should be aware of. The PANS, I think most of you are familiar with, the Positive and Negative Syndrome Scale, has 7 items dedicated towards negative symptoms. There's also the dedicated SANS, a scale for the assessment of negative symptoms, and also some newer instruments as well, the NSA, which we'll talk about some more, and the CANES as well. People have heard about the CGI. This can be used as a global assessment. And then there are functional outcome scales. So the PSP and the SOFAS are scales for the assessment of functional outcomes, which in the end is often what we want to know, is not do you have negative symptoms, which is important, but how does that translate into what you do as a person? What are your roles in life and how are you functioning overall?
Great. So we have a polling question. We'd like to ask the audience, which tools do you think may be used together to assess negative symptoms, disease severity, and functioning during a 15-minute med check? So you have 4 choices, and please give us your thoughts. Okay, let's take a look at the responses that we have. So what I'm seeing is that 51% of the audience chose the NSA-4, the CGI, and the SOFAS. Jonathan, what do you think about that?
I think 51% out there are quite sharp. Many of you have not heard of these instruments, but the CGI is something that everybody does every time you see a patient. All this is a 1 to 7 point Likert scale of the rating of severity. So every time you see somebody, you say in your mind, this is the sickest person I've ever seen, which will be a 7. This person doesn't look ill at all, which will be a 1 or somewhere in between. Easy to do. You're already doing it mentally. You just have to write it down. It would take you 5 seconds. The SOFAS, many of you have not heard of. But this actually looks very much like that old GAF score, which we're not supposed to use anymore. 1 to 100 scale of functioning. The wording often looks very similar to the GAF score, but there's no symptoms in it. It's just functioning. So again, an easy number to put down, just like the GAF score. You'd put a number down. There are some anchors. They could be a little tighter. The one I think most people aren't familiar with, but I really hope you'll go home and look this up a little bit because it's in the public domain, is the NSA-4. Some smart people have taken the 16-item NSA and figured out that really 4 of these items are all that are needed to get the predictive value of the larger scale. 2 items on diminished expression, 2 items on apathy and avolition. And again, if you had the printed form in front of you to actually circle the numbers, would take you on the order of seconds. And so this is something that really wasn't available until a few years ago. But I think it's going to become a more and more standard practice, especially because getting a handle on negative symptoms is maybe a little more challenging than it might be for other types of symptom assessments in the office.
And Peter, what's your take?
Yeah, I think that's great. And I think that for those clinicians like myself who tend to use them, or I use them in research, not so much in practice, I think there's an awareness that they need to be simplified and made clinician-friendly. And that's really the main take-home point here, is that there are clinician-friendly measures. If I had to use one thing, I like to use the CGI, the Clinical Global Severity or Improvement Scale, and use it just for the overall negative symptoms for that patient, because then I can calibrate that patient's progress for that patient's own negative symptoms based on my clinical judgment. And if you're experienced in schizophrenia, you'll be able to do that.
So how about the difference between observed and elicited?
Yeah, and that's the idea of different kinds of negative symptoms, that there are some that you're going to observe. When a patient walks into your office, they won't make eye contact. There's a long delay in response. They won't have anything to say. They may have obviously poor hygiene, or the family or case manager will tell you exactly the same thing. These are, in this slide, in the pink on the left. These are things you observe in the person. It's not an internal feeling state. In the blue on the right is more, what is that person's internal drive and experience? And generally, the ones on the right are subjective indifference. The person just doesn't feel anything. No loneliness, no lust, no interest, no pleasure, that kind of thing. And you can interview for that. Patients aren't going to tell you, oh, I just don't feel anything. So you need to kind of do a gentle interview to kind of work with the individual to kind of get at that. There are certain interview techniques on that. You look for kind of the absence of those internal feelings. So that's, I think, one of the things that takes a little getting used to, and then you can do it.
And how important is an informant in that process?
I would say for the internal state, an informant is helpful, but they're not going to understand the nuances. So for example, if someone is just not motivated, are they hearing voices so they're not going out? Are they depressed so they're not going out? Or do they just have no drive or interest? Informants often can't fine-tune. That will take a little bit more training and in the subjective. I think the objective stuff, the informants, they're going to tell you, my kid isn't bathing, my kid isn't getting out of the bed. That's going to be easy. But the subjective, I think, really often is the clinician.
Okay. So can you give us a couple of examples of one or two questions that you might use to determine whether someone has negative symptoms and to gauge their severity?
Yeah. Well, one thing I'm often going to do is, if they're not functioning, is try to assess what's going on. And is it that they're fearful, paranoid, restricting activity? Is it they're depressed? Or is it that they just have no internal drive? So that's one thing. For the subjective stuff, which takes a little bit more training, I try to drill down. I try to see what they are doing during the day. I don't want to be too much of a doctor, but more, what are their interests? I like asking about TV, because most people watch TV. Do they have favorite shows, or do they just watch one show after another and don't care what they're watching? If they have favorite shows, do they go out of their way to see those shows? In terms of sociality, if they're living with their family, are they watching TV with the family in the family room, or in their own room when their family is watching the same show elsewhere? So those are the kind of really drilling down to the quality of that experience I find helpful.
Jonathan, do you have anything to add to that?
Actually, it's very similar to what Peter is asking. You know, often you have observable data, but if you can elicit some of the subjective sense of what are their interests, you know, do they actually have anything which they derive pleasure from? Do they have social interactions? You know, so I'll ask people, what are things you enjoy doing? TV, again, is a great question. And as Peter was saying, not only do you watch TV, which many will be present in the room where the TV is, but I'll ask them, can you tell me your favorite program? And it'll be surprising how many people who spend hours watching TV with significant negative symptoms could not name the program, and will have even trouble describing the types of programs that they actually watch. And that really tells you that there's a really diminished internal experience there of what's going on with the world.
And Peter, what about mood disturbances?
So let's drill down on mood disturbances. As John, you mentioned, many patients with schizophrenia also have depression. By the way, you can have depression and still have schizophrenia. It doesn't exclude the diagnosis. Now, it's harder to diagnose depression and schizophrenia, because if you're not functioning work-wise anyway, you can't use loss of functioning. as your criteria for depression or concentration. So you usually have to use in a depression interview feelings of hope, internal dysphoria, sadness, hopelessness, giving up, painful emotional states. And so that is going to be your tip-off for depression. Negative symptoms, the person's not doing anything, but they're okay not doing anything. So a person with negative symptoms might not want to go see friends because they're not lonely, they don't care, whereas someone who's depressed might say, well, it's because no one would want to be with me, I'm just no good. So it's that depression tends to be subjective depression, dysphoria, self-hatred, self-loathing, hopelessness, whereas negative symptoms tends to be just the sort of indifference. There's just, you're not there emotionally. So it can look similar, but the emotional experience is very different. One other very important caveat, and there's some examples here. So I often ask about if someone has no friends, are they lonely? If they're not lonely and they feel like they've got lots of friends, even though they haven't seen anybody in years, that's more likely to be negative symptoms. If they feel lonely, they want to be with people, but they feel like they put themselves down, then that's more likely to be depression. One caveat is that if a person is depressed who also has negative symptoms, you need to ask about that depression because they will not look depressed because of the negative symptoms. They look flat. You have to ask about the hopelessness and the suicidality. So those are just some broad overview of this differential.
Great, thanks. So, Peter, you mentioned that patients don't complain about negative symptoms, but that the caregivers often do.
Yeah, and I think all of us who've worked with this, I'm laughing not because it's funny, but it's a basic thing with caregivers is that they're going to, they will have gone through their, and I'm going to usually use their adult kids' psychosis. They go back home, the kid goes home, and then the family's beside themselves that, oh, my kid is lazy, he just needs a kick in the ass, that kind of thing. They're identifying that the person is not motivated, but they are not aware that it's a negative symptom. So it's classic.
And Jonathan, is there anything else in the patient's demeanor or level of distress that helps differentiate between negative symptoms and depression?
And I think, as was mentioned, really it is the effect of distress which will often tip you off that this is something which is a change. Persistent severe negative symptoms tend to be very stable over a long period of time, tend not to fluctuate very much, and don't engender a lot of complaint from the individual themselves. Whereas depressive episodes tend to follow a course of depression where there is a certain amount of dysphoria, a certain amount of distress. Certainly if people saying I'm suicidal, this is not a negative symptom. And so the overall course may help as well as the subjective response to the level of complaint.
Okay, great. Well, let's move along.
Yes. Yeah, so the other, again, when we were talking about these sort of differential things, the other one, John, that comes up, since we talked about cognitive dysfunction and negative symptoms, what's a negative symptom? What's a cognitive dysfunction? And that there's a whole, clinically it can be very difficult to tell, but if someone is having cognitive problems, so they can't find their way to the clinic because they can't read the bus schedule, or they can't remember what to do to pick up their cell phone, that can be a bit different than someone who is not motivated. So having said that, clinically it can be a little bit challenging, but we need to keep in mind that often patients do have both cognitive and negative symptoms. I do like to ask about how frustrated are they with their concentration, attention, and that is a different area than negative symptoms clinically.
How else might you differentiate between negative symptoms and cognitive impairment?
Well, again, I would want to say that the honest answer, John, is it's not always possible without neuropsych testing, but clinically what I do look for, let's say someone is someone who has negative symptoms. Why aren't they going to the movies anymore? They don't care about seeing the movie. They're not interested. Someone with cognitive symptoms, they might want to go to the movies, but they go to the movies and they just don't get it. They can't remember it. So, like, why bother? Or that kind of thing. If someone's just unable to follow through with things, that's going to be more likely to be a a cognitive symptom. So those are the things I will do clinically.
Okay, great. Let's take a look at the next slide. So we're now going to get into a discussion of the role of neurotransmitters, and I think it's important to have a historical perspective when we talk about that. So Peter, could you kind of just take us quickly through the evolution of our understanding of neurotransmitters?
It reminds me of these tests, does, in 2 sentences say, does God exist? It's a very complicated thing, but very briefly, we don't know what schizophrenia is, and there were many theories for hundreds of years. But modern pharmacology came with the discovery of the neurotransmitter in the 1950s. So there are a bunch of different neurotransmitters: serotonin, norepinephrine, dopamine. They all had competing theories. The one that survived was the dopamine hypothesis of schizophrenia. Now, stay with this, because there are different versions of the dopamine hypothesis of schizophrenia. The first one that was put forth in the middle of the slide by Dr. Carlson, who won a Nobel Prize for this, was that excess dopamine caused schizophrenia. The lines of evidence was amphetamine psychosis. People taking amphetamines looked like they had schizophrenia. That the antipsychotics at the time made people Parkinsonized, and at that time it was discovered that Parkinsonism was too little dopamine. Amphetamines resemble dopamine, so dopamine was prime suspect number 1. So that's the initial dopamine hypothesis of schizophrenia. Like our software programs, those hypotheses get revised. So there's 1.0 dopamine hypothesis 2.0, but the basic dopamine hypothesis 1.0 is that too much dopamine is the cause of schizophrenia, because amphetamines are like dopamine, and antipsychotics block dopamine, cause Parkinsonism. That was the, now, many years later, lots of different hypotheses, you're going to see that a lot of the hypotheses of schizophrenia have to do with drugs of abuse that cause symptoms that may resemble schizophrenia. The glutamate hypothesis was proposed as being another model for some of the problems in schizophrenia. And that goes way back, now way back to the 1980s, and has really been there now for over 20 years. But I don't know about you, but I certainly, as a clinician, didn't really think along those lines until a lot more recently. And it's really going to be very exciting to present to you some of the evidence for this in the next part of this program.
So our next polling question is, why was the original dopamine hypothesis revised? And you've got several choices. A, most antipsychotics mainly treat psychotic symptoms. B, LSD also elicits symptoms that are similar to some positive symptoms of schizophrenia. And C, hypoactivity of frontal cortical dopamine neurons was found in animal studies. So you have those choices. You can also answer A and C, or all of the above. Okay, please try to give us your answer.
Are there red states and blue states, John?
It's hard to tell. I think that's a tough question, so we're getting kind of a slower response. But so far, about 50% of people are saying all of the above.
Okay. Honestly, I personally think there's, it depends how you interpret this question. I think that when we formatted this question, A is clearly true, in the sense that the dopamine hypothesis version 1.0 was great for explaining psychosis, but it was terrible at explaining negative symptoms or cognition and all the other stuff in schizophrenia. So that was a big shortcoming of the original dopamine hypothesis of schizophrenia. The second choice, LSD, that was a competing hypothesis at the time. So it competed with dopamine hypothesis, but it wasn't really the cause of the revision of the dopamine hypothesis. So probably that B is not correct. And C is too little dopamine in one part of the brain in schizophrenia. That is correct. So let's look at, dopamine hypothesis version 1.0, the one that I described before. That's in green on top. It explains positive symptoms very well, but not so much anything else in schizophrenia. Certainly does not explain negative symptoms. So the revised dopamine hypothesis in blue said, hey, we can explain negative symptoms by having dopamine hypofunction in the cortical area of the brain, too little dopamine in certain parts of the brain, relaying and driving too much dopamine in other parts of the brain. So I'd say the revised dopamine hypothesis is certainly superior to the initial one because it explains at least some cognitive and negative symptoms as well as positive symptoms, that there's too little dopamine, too much dopamine, but it still has problems in the sense of explaining all of the symptoms or the course of the illness and really drove researchers. So it was an advance in the 1980s. So like many things, one advance leads to other questions.
So let's go on. And Jonathan, can you tell us about the receptors that are involved with different neurotransmitters and how they might be relevant?
Well, a lot of what we've learned about psychosis is the fact, as Peter mentioned, there are many pathways to psychosis. The amphetamine model was very, very useful because it allowed us to generate a whole series of compounds which were all dopamine antagonists and which were effective antipsychotics. The problem is, of course, as was mentioned, we have this competing hypotheses of other transmitters which seemingly can cause psychosis, such as LSD, which binds to serotonin 2A receptors. It's an agonist there. It causes psychosis. And then lastly, we have drugs which act on a subtype of glutamate receptors called NMDA. So both PCP and ketamine are NMDA antagonists, and these drugs, when administered to animals and human beings, caused a spectrum of psychotic symptoms, along with other aspects such as cognitive deficits and negative-like symptoms, which maybe more look like schizophrenia than we saw with either amphetamine or LSD. But all of these are contributory and certainly reveal the level of complexity in the development of psychosis.
One question I had about when you look at those transmitters, it's drug abuse that seems to lead to these hypotheses, which then lead to further understanding. But the glutamate receptor here looks different than the dopamine and the serotonin receptor. It looks kind of funky relative to the receptors I know. So I guess we'll get into that a little bit later.
Yeah, I don't mean to interrupt, but actually we can see here where or why the glutamate hypothesis started to actually come to fore. So if we go to the next slide here, the glutamate hypothesis, I think for the reasons you mentioned, we were getting something funky from these glutamate antagonists we weren't getting from amphetamines. Amphetamines make people paranoid. If you use a lot of them, you'll start to hear voices. You don't get cognitive deficits in either human or animal models. But the glutamate antagonists really kind of showed something different. And specifically, when we're going to talk about the glutamate hypothesis, really the glutamate hypothesis is one of NMDA receptor hypofunction. So there are many types of glutamate receptors. Glutamate is the largest neurotransmitter system in the brain. It's an excitatory neurotransmitter. You have various types of receptors, some which open ion channels, some which go to second messengers. But NMDA is one subtype of these, and these drugs, PCP and ketamine, are NMDA antagonists. And it was recognized that we're getting something here from these drugs that we don't get from other types of drug exposure which cause a certain form of psychosis, which is very limited. And then this has been bolstered by experimental evidence after that, including some genetic studies which have showed that in human beings with schizophrenia, we see some polymorphisms in genes which are involved in glutamate neurotransmission.
So Jonathan, what do you think is the strongest evidence in support of the glutamate hypothesis? Is it animal models, is it human studies, or is it the genetic findings?
To be honest, I think you have to say it's both, because the initial animal and human exposure really looks very, very good, and it gives us things which we don't get from those other types of drugs like cognitive deficits. But I think the whole model is really bolstered by the genetic findings. When you start to find genes in people with schizophrenia which are associated with risk of that illness, and are involved in glutamate neurotransmission in some way, then it really kind of ties the whole story together. And I think that's perhaps the most compelling piece has been those recent genetic findings.
So if you look at a normal NMDA receptor function, can you explain a little bit about how that requires glutamate and glycine? And
Yeah, it's a little complicated. You know, most of us are used to thinking of dopamine receptor. Well, what binds to the dopamine receptor? Well, I think the audience all knows that it's dopamine. The glutamate receptor family is different, and NMDA in particular is a little complicated. The NMDA receptor actually has a coagonist site. So glutamate will bind at one portion of the receptor, and there's actually a coagonist site which binds primarily glycine, but can also bind a D-amino acid as well. So we have something which requires multiple things for it to do its thing, and potentially there can be problems in one or more of these areas. The other thing having to do with glutamate is because it's the largest neurotransmitter system in the brain, is that there's important aspects of glutamate in terms of function and development. I think most of us recognize now that schizophrenia is not a disease that develops when you're 16. It probably develops in the second trimester, with all the literature about women who have influenza or other stress exposure in the second trimester. So we recognize that while NMDA hypofunction may manifest in a certain way in an adult, it's probably doing something very different in utero with wiring and synaptogenesis, all of which contribute to some of the abnormalities that we see in the mature brain which has schizophrenia.
And even though it's a complex system, it also suggests there might be a number of different ways that we could intervene.
Well, I think that's the goal. I mean, we would like to actually have markers which potentially early on, and people who are still high risk but haven't developed schizophrenia, in going on to develop this, if we could divert the course by some intervention yet to be defined. The other thing, of course, is that if you have this model, this may allow us to unravel the etiology in people who already have the disease, perhaps find novel approaches to the illness. So there's a lot of things here which give us greater explanatory power with the glutamate hypothesis, specifically NMDA hypofunction, which covers the whole spectrum of the illness in the way that the dopamine hypothesis 2.0 or 2.1 didn't quite. I think we've mined that model and gotten as much of it as we could, and we've started to recognize that we need a more overarching hypothesis to help us further advance this illness and its treatment.
So what do you find most compelling about this model?
I think it's the explanatory power. You know, the dopamine revised hypothesis allows us to understand positive and negative symptoms to some extent as really disparate dopamine problems. But then already you're starting to say, well, we have two distinct problems going in the opposite direction, whereas the NMDA hypofunction hypothesis allows us to say NMDA hypofunction is related to both of these things. That NMDA hypofunction is associated with too much dopamine in the mesolimbic pathway, too little. We can give NMDA antagonists to animals and give them cognitive deficits, and it gives us the whole package of schizophrenia in a way that we didn't with other hypotheses.
And also the number of genes that have been implicated
Yeah.
related to it is also striking.
Yeah, absolutely.
So, you know, we've covered a lot of territory, and we just want to briefly summarize some of the things we've talked about. First, schizophrenia is clearly a serious public health issue that affects millions of people worldwide and has very far-reaching consequences. The symptoms of schizophrenia fall into three core domains: positive, negative, and cognitive, with additional features such as mood symptoms. Diagnosis and diagnostic tools are continually evolving, yet careful observation and questioning remain the cornerstone for diagnosis and differentiating symptom domains. The dopamine hypothesis has guided the treatment of schizophrenia for decades. However, on its own, it may not fully explain the symptoms that we see in this illness. The glutamate hypothesis of schizophrenia is supported by the observation that substances blocking NMDA receptors can result in symptoms that resemble the positive, negative, and cognitive domains of schizophrenia. So that is very exciting. So I want to thank Dr. Meyer and Dr. Wyden for their participation. This concludes the discussion portion of our program. We'd like now to begin our question and answer session. If you have a question and have not already done so, please type the question into the Q&A tab on your screen and click the Ask button to submit the question. If you're joining us by phone and would like to ask a question, please press *3, then 1 on your telephone keypad. Let's begin with our first question. Do you think that clinicians recognize the high prevalence of negative symptom domains in their stable outpatients? And if not, why not?
I think let me tell you this statement that they do and they don't. I often hear from a clinician that this patient is doing well. And then you see the patient. And if you calibrate that to how the person would be without schizophrenia, you'd say, what's going on here? The person is disheveled, not working. So what is the clinician really saying? The clinician is saying, relative to my experience with schizophrenia, this person's positive symptoms are controlled. But I would say that's not doing well in terms of life. So I think if you kind of pin that clinician down and say, do you really mean well, like, you'd want this person to go out with your daughter? Or is this person fully functioning? They would clearly recognize it, but it's not even on their radar screen. So I think it's almost like an Anton syndrome. It's almost like not recognizing what's there.
So in a way, we've lowered our expectations also.
Yeah.
We've kind of accepted this lack of functioning.
Sadly, the negative symptom patient causes us less problems as clinicians, unless it becomes really severe, and let's say the person doesn't shower and their hygiene becomes a problem. But, if you have somebody who kind of sits at the boarding care and smokes cigarettes and doesn't kick up too much of a fuss, I hate to say it, that's the easy patient as we think of in our patient pool, as opposed to somebody who's irritable and hallucinating and agitated or whatnot. And so I think sometimes we do let these people slide. I think there also is some therapeutic nihilism too, because even if we take a step back, like Peter is saying, and realize this person's not really functioning, we're often at a loss about what to do about it.
When do you think negative symptoms first emerge? Is it something that we see at the onset of the illness, or does it tend to get worse over time?
I would say I've seen it both ways, John. Some people, the onset, and I think this is one important thing, I know we've discussed this personally. When we say onset of schizophrenia or first episode schizophrenia, that means it's the first time we've seen the patient as clinicians. It's really more like first presentation is more accurate. That person may have had psychotic symptoms or negative symptoms or cognitive symptoms for years. So there are going to be many people who have quote unquote first onset of schizophrenia to us, but really have been suffering from that, and including negative symptoms for many years. And there are other individuals who seem to have more intact in the sense of not having negative symptoms, and then as things go on, it really, you see it more and more in their lives.
And we didn't talk a lot about the potential secondary negative symptoms, and I know, Peter, you've done a lot of work on things like akinesia, and is it possible that sometimes we're seeing drug side effects that can mimic negative symptoms?
And John, I just want to say you were my mentor on the akinesia work, so I learned that from you. But yes, because of medications having lowering dopamine, we can see the behavioral effects that look just like negative symptoms. It's less of a problem with the newer generation antipsychotics, but it's still there. You can cause behavioral apathy, for example, from medication, and that can be hard to tease out. The other thing, John, I see a lot in my practice is to tease out psychotic symptoms from negative symptoms. So I remember very vividly a woman referred to me for negative symptoms because she didn't bathe for years. So you can imagine this did not win awards in her home. And I had to use air freshener. And so that was a negative symptom consultation. But this was from a Jewish family, and she had the delusion that if she turned on the shower, it would be poison gas from Auschwitz. So the treatment plan for her was not negative symptoms, but to elicit positive symptoms that had not been forthcoming. Once we elicited that, we then moved to other medicines more appropriate for treatment-resistant schizophrenia. So look for positive symptoms maybe driving negatives, and that can also happen.
So again, it's the importance of the clinician doing a thorough assessment and considering all of these possibilities. The next question that's come in is, do you believe that the Calgary scale for depression and schizophrenia will be useful as a clinical tool to differentiate between negative symptoms and depression?
It's a tough one. You know, the Calgary scale has been developed specifically for patients with schizophrenia. I think the hard part is that there's going to be some overlap with the negative symptoms. And as we have talked about, often you're going to have to rely more on perhaps other elements because you may score a certain amount just by your negativity alone. And so looking at the trajectory of the complaint, as Peter was talking about, looking at the subjective level of the stress, I think there's going to be other elements. And then, of course, lastly, how many of you out there are actually using the Calgary scale? We're hoping
someone asked.
We're hoping, and I'm glad somebody is, but we're hoping at the end of this, at least you'll look up the NSA-4, which is only 4 items easily scored. So I hate to add another scale to your plate. So for that reason, I'll say it may not, although there may be some use for it, but I think the clinical assessment is probably still going to be more important for those people for whom this is the part of the differential.
But I think that's a good segue into a little bit more discussion about the use of rating scales. And I mean, I've certainly been struck that in other areas of medicine, people have lots of quantitative measures, objective measures, lab tests, x-rays, cardiograms. In psychiatry, we rely on a lot of subjective impressions and judgment, yet we don't do a good job of quantitating that. And I know in my own hospital, we've had some resistance from the faculty in terms of using rating scales. And I guess I wonder if we are systematically asking the questions that we've all discussed, does it really take that much more time to put a check mark next to a 3 or a 5? And perhaps do you think there's like too much resistance to doing this? What do you think the issues are?
I think the hard part, John, is actually having this stuff readily available. So if you have, let's say, an electronic medical record, there has to be a template there which is easily placed in the patient's record, so the clinician doesn't have to figure out what are the anchors for the CGI, what does a 4 or a 5 mean. They can just say, oh yeah, I know exactly how sick this person is. Same with the NSA-4. If that was an easily imported template, they wouldn't have to find the paper, find what it is, put it in the chart. You just do it that way. If you're still using paper charts, same thing. If you have a printed copy of the CGI and the NSA-4, taped to your desk, or it comes to you with each patient's record, very easy to fill out. But I think what happens is because that hasn't been part of your workflow, the idea of trying to incorporate something, people just don't have a mechanism for doing that. They don't know where to find the instrument, even if it's a CGI. I think that has to be provided to people on a regular basis, and I think when that happens, it'll be a little bit easier. There will be less resistance.
And also the training to use it. So, and I think
Yeah.
in most of our residency programs, we're not really teaching our trainees how to use rating scales, and maybe
Yeah.
if we did that more, that would help.
Yeah, I think for many people, a rating scale seems like a research kind of a thing, a PANS, lots of training, very hard. It doesn't have to be that way.
But I also think there has to be a sensitivity to this. The electronic medical record has been, to be generous, a two-edged sword, and clinicians have been dumped on a lot with a lot of what they will perceive as a lot of irrelevant things they're supposed to fill out. So I'll give you an example. In our admission form, we had to use an addiction severity index scale if anyone had any substance abuse. For those of you who know the ASI, it's a hugely cumbersome thing that's like overkill. So I think that this is I think one of the exciting things about the NSA, or the things we're talking about, is there's now been more sensitivity to the demands on clinicians to really parse down these scales to what is most relevant and consistent with what they're doing in practice. And I think that we do that if sort of administrators or the field does that more, I think clinicians may be more likely to come on board.
So another question that's come in is a rather sophisticated one addressed to you, Jonathan, about glutamate decarboxylase. being the target antigen of human monoclonal islet cell antibodies.
Boy, am I glad you got that one, Jonathan, not me.
Is there a potential relationship between diabetes and some form of schizophrenia based on this association?
There is certainly a relationship, but I don't know that specifically based upon this biological hypothesis, although it's quite intriguing. And many of you know from the work I've published, and many others as well, to have a severe mental illness such as schizophrenia doubles your risk for metabolic dysfunction, both metabolic syndrome and diabetes mellitus. But I don't think we fully have unraveled it just yet. And this may be one of those things where we might see a relationship. But sadly, often a lot of these genetic associations come back very weak. They're positive, but they're weakly positive. So they explain a certain percent of the risk, but it's often very, very small. So I have a feeling, because schizophrenia is genetically a complex disorder, meaning hundreds of risk genes involved, and type 2 diabetes is a genetically complex disorder with a number of risk genes involved, it probably won't be such an easy correlation, unfortunately.
Can I answer something I know a little bit about? I don't know anything about what this questioner is, but one thing that intrigued me is that there's an expanding literature on gluten sensitivity and psychiatric disorders, and that it seems like there's a lot of evidence that that is also a glutamate NMDA antibody that can cause psychiatric difficulties, gait disturbances. It's not just when I was in medical school, you learned about gluten as celiac sprue, and I think that if anyone wants to pursue that in their readings, read a review on gluten sensitivity, and I think that will be a very interesting NMDA model as well as what we're learning in schizophrenia.
So obviously there are many different perspectives with which to approach this. The next question that came in is, and this certainly applies to many patients with negative symptoms, and why do patients with schizophrenia smoke so much? And certainly, even we're doing a first episode study, and we see that half the patients are smoking at a very young age.
Yeah, actually, there was a great article published very recently, and I'm not positive the journal, let's call it Schizophrenia Research, but I think you should look it up. So there's a man named Tony George who's been doing this research for many, many years, first at Yale, now up in Toronto at CAMH. The leading hypothesis has always been one of cognitive remediation, that nicotine will transiently normalize some cognitive functions. But the latest studies indicate that that may not be the case. And if that's not true, then what are we left with? I think what we're left with is the fact that these are people who are experiencing negative symptoms, anhedonia, and nicotine is one of the most readily available forms of a substance which we can stimulate the reward pathway. And that's just sort of my personal opinion, but in the absence of the viable cognitive thing, which we kind of hung our hat on for many years, I think we're left with deficits in reward signaling and nicotine being cheap and available. And abuse is not limited to nicotine. Nicotine is the most highly abused substance, but then, you know, alcohol, the risk for all substance use disorders is many-fold greater in patients with schizophrenia. So I have a feeling this may emerge as perhaps the leading hypothesis for all substances of abuse.
Okay, well, thank you. Unfortunately, that is all the time we have for questions tonight. So I'd like to thank you all for your great questions and for participating in this program with us. And before you exit the program, we ask that you take a few moments to complete a brief survey, as your feedback is very important. And have a wonderful evening.